But very much tonight is around the how to teach. And I would like to hand over.
What we're looking at now is the range of ways that you can use that hour, half an hour of dedicated teaching time. There's lots of choices of things that you can do in that time, not just casually discuss cases, although that does tend to be the default setting. Depending what you're trying to look at, what you're trying to teach, your method of teaching will vary. And it's worthwhile mixing it up for a couple of reasons. For your own satisfaction, because it's more effective to try different methods, and certainly more interesting for the registrar as well. So what we're going to do is have a think about all the different ways in which you could use different methods to fill that teaching time with your registrar. So here's a list of teaching methods we prepared earlier that could be used in, and it looks like an inordinately big list, but you can see that there's a large number of case-based discussions. There are topic tutorials, demonstration as a way of teaching, particularly procedures, and role modelling and role playing. An audit can be useful if you're organised, and certainly exam preparation and exam teaching can be useful depending where your registrar is in their training. So looking at that enormous list, you might look at those and think, well, yeah, that kind of makes sense. Most of what you're going to be doing will be somehow related to case stuff. And I would say that probably the next most common thing you'll use your time for is some kind of demonstration of some sort. Topic tutorials, which we'll talk about in a little bit, are not the bread and butter necessarily of that teaching time. They have their place, but maybe not as often as you might have thought. All right, so look, what I was going to do is just go through and really just pick out the essential highlights of each method, why they might be useful and what they're best used for. The main thing about this teaching time is just that you plan it ahead, that you intend to do it next week. You don't have to necessarily have a term-long schedule of every single thing you're going to do, but at least be planning for next week what you're going to do. Direct observation, a lot of you will obviously think of it as mainly done as assessing your registrar, and of course it's a fantastic way of seeing with your own eyes what the registrar is actually doing, as opposed to what they did do in the past or what they would do in a hypothetical. You see them in action. Clearly, it's a fantastic opportunity to do real-time teaching, and I think the main strength is that you get to see exactly what's happened, and then you get to give feedback immediately as it's happened, or teaching immediately while the patient is still fresh in their mind. And in fact, sometimes even while the patient's in the room, but usually once the patient has left. I think in particular, it gives you an opportunity to do what you might think of as coaching. By that, I'm thinking of the act of giving an instruction, watching it be performed, and then giving immediate feedback, and then they do it again, and then they do it again, and then they do it again, like a tennis coach hitting balls at you all the time. The advantage of direct observation, particularly for communication and consulting skills, is that you can watch the registrar. Perhaps they looked at their computer too much in the consult, or perhaps they talked over the top of the patient. The patient leaves, you can give them that feedback and then watch them the very next patient and see whether they do it again. It gives them an opportunity to then refine what they've done, and you can go, yeah, look, that was a whole lot better. Try this again. I think that's one of the magic things about direct observation in terms of teaching. As I said, we know about it as an assessment tool, but it's a really good opportunity for teaching. Some of you might be teaching visitors. I've certainly done a lot of teaching visits, and although the assessment part of it is promoted, it really is a very valuable, and once the registrars are used to it and accepting of your presence in the room, they generally find it an incredibly valuable experience. So you can schedule, if you want, your teaching session, your hour, instead of doing some cases, say, look, book a couple of patients and I'll sit in with you and we'll see how you go. We'll give you some feedback as you go. It's just a matter of scheduling it to make it happen. It doesn't have to be just when the training provider tells you you have to do it. It's worth doing the whole way through the term. Random case analysis is a brilliant way of teaching a whole range of different aspects of the case. Random case basically means discussing a case that is not brought to you by the registrar because they've got a problem with it. It's randomly chosen from maybe the last couple of days worth of patients. And the biggest strength, as you can imagine, of being random is that the registrar doesn't necessarily know whether they've done everything right or not. They haven't presented it to you because they probably thought it went fine. But you can uncover an amazing amount of hidden or blind or unknown unknowns by looking at what they've done and thought that they were doing fine. It's not about just picking the holes in everything that the registrar's done, but it's about revealing what has been done, without the registrar's filter of presenting that to you. So that adds an awful lot of power to the teaching. You can then explore and interrogate the case like you would with any case. Why did you decide to do this? What other things did you think of? What investigations? Why did you choose that medication? So as a way of figuring out and then teaching clinical reasoning, it's a fantastic way of doing that. And the other really important aspect of random case analysis, which just increases its power, is the ability to add the what if questions. In other words, even the most banal, seemingly simple case, you can turn into something interesting by going, okay, you did that really well, but what would happen if this person was 40 instead of 20? Or what would happen if this person has chest pain lasted an hour instead of a minute? Or what would happen if you were after hours? Or you can add whatever you like. It can be quite playful, in fact, and you can turn even the most simple case into something that's really rich for discussion and teaching. There is a very, very well-written, clear GPSA guide on doing random case analysis, which I absolutely recommend. There's a few things you can do to value add to your case discussion. And one thing that you can do, it's kind of like random case analysis, but rather than analysing the whole case, you're really just focusing on the test ordering that was done during those cases. So it can still be randomly chosen, but you're looking at what tests were ordered, and of course, with a focus on why did they order those tests as a reflection of clinical reasoning and maybe even managing uncertainty. Is someone ordering a shotgun blast of tests for every little thing? Perhaps there's an issue of uncertainty, intolerance of uncertainty that you're dealing with. Rational test ordering as a skill and as an attitude and as an approach is very important teaching, and it's something that needs to be reiterated all the way through training. It's a good exercise to do, as I said, just choosing random cases and looking at the tests that were ordered. Or another way of doing it is literally just sit down and open their holding file of the results that have yet to be checked off and skim through and choose a few investigations and get the story behind them. And again, querying, what was this about? What was it going to tell you? How was it going to change your management? It can be a very, very useful teaching method. Within your case discussion, rather than actually deliberately spending all hour looking at referral letters, it can be really quite interesting focusing on referral letters. The referral letter has a few interesting features that are worth assessing, but also teaching about. To write a good referral letter, as you know, you need to be able to really succinctly represent the problem. You need to not blurt all the unnecessary stuff in the world. You need to frame the problem as succinctly as you possibly can. And you need to give the doctor you're referring to a really clear reason for why you're referring them. What's the question, or what's the problem that you've got? What's the reason for the referral? It's quite a skill, and it's worth looking and seeing how it's done and improving, giving feedback on how it can be improved. Obviously, it's also useful in terms of assessing someone's communication, particularly written communication skills, and how they communicate with a fellow doctor, with a colleague. It's a useful thing to do within random case as well. The last thing you can have a look at when you're looking at doing a random case is having a look at how prescribing went. What did they prescribe? Why did they choose it? You can focus on, was it safe? Was it a rational choice of prescribing? And it also can be an opportunity for you to review guidelines, particularly therapeutic guidelines, review or teach about PBS rules and so on. So that can be a nice little focus you can do on a couple of your cases when you're discussing them. Critical incident review, and I think they're a really important thing to pick up on. Obviously, they're an incredibly stressful thing to happen for everybody that's involved, but they are a magic opportunity for teaching, as long as you keep the process obviously very safe for the registrar, because the levels of stress can be quite high associated with it. The teaching is very much about, how did this happen? What were the steps that led to it? And of course, importantly, how can we prevent this from happening again? Clearly, the focus is on making sure from the practice and the patient's point of view that safety is maintained. But we learn from our mistakes. We don't like to actually face up to them. But as a supervisor, if you can provide a safe, blame-free, shame-free space for registrars to say, look, geez, I really didn't do this well, this didn't work out well, or maybe a near miss where things could have gone wrong but didn't quite, there's an awful lot to be learned from it. As a supervisor, to turn this into something valuable and to make it work, it can be incredibly helpful if you're prepared to share your own mea culpas. You don't have to give names and pack drills, but you might have a story of when you were back in the day when this happened and things didn't work out well, and it was terrible and you felt horrible, that this is what we did about it and this is what I learned. You do learn from your mistakes, and it's fantastic if you can help the registrar to go through that process. Even better, if your practice is organised enough to have meetings where you discuss cases that went wrong. It normalises the process and it removes the individual from the process. It's just part of quality assurance, quality improvement to review those. So strongly recommend having a look at critical incident review. Most of you probably assumed, if you're new supervisors or about to be supervisors, probably think, God, my teaching time means I've got to stand up there and deliver a 26-week program of topics, complete with PowerPoint slides and videos and a lecture series. Look, nothing could be further from the truth. Topic tutorials have their place, but doing a session on atrial fibrillation or gout is probably a waste of your registrar's time, in the sense that they can read up about it. They can read the latest text or the latest guidelines or attend the latest course on the actual knowledge topic. Most of us as GPs are not really contact experts on any particular topic. What we are experts at is at being GPs, and we're very expert at the context rather than the content of what presents. So if we're going to do a topic tutorial, it's really important to try and relate it to cases. Now, whether they're real cases that you bring or the registrar brings, or made up cases, having cases as part of a topic session is incredibly valuable, because it allows you to show how you would process or how you would go through sorting this patient out. Some of you might have clinical expertise, some of you might be doing healthcare or sports medicine or drug and alcohol, and you may actually have some content expertise that doesn't come easily from textbooks, and by all means, please share that. But don't feel that if the registrar comes up to you and says, look, I want to learn all about the pill, point them to something, the family planning guidelines, or point them to a resource. But then instead of you delivering a lecture about the pill, you might deliver some cases about the pill and look at how that relates to the knowledge that they've learned. You are, as GPs, experts at, it's about some of the processes of general practice, which again are an important knowledge to know. We're content experts on maybe things like work cover or even care plans and billing and so on. That's not easily got out of books or resources, and running a session on care plans is a fantastic thing to do. References and guidelines can be useful to look up during the topic tutorial. And don't forget, this is an opportunity for you both to learn together. Registrars have got a lot to teach us as well. There are resources on the GPSA website. There's a whole suite of teaching plans which are very topic or presentation specific. And if you haven't already looked at those, they're terrific teaching aids when the registrar asks you, can you teach me about such and such, rather than going and looking up the topic. That can be one way of doing it. The last thing that you can do with a topic, if the registrar is really keen to ask you about it, is turn it around and say, well, how about next week you give me a 10-minute presentation and then we'll talk about how that applies to some cases. We're going to quickly talk about some other methods of teaching, demonstrations. So these are all kind of demonstration skills, and I'll just quickly whip through what they're useful for. Look, reverse direct observation is incredibly valuable, where the registrar sits and watches you in consultation. Clearly, most of you have or will probably do this at the beginning of a term, particularly with the term one registrar who's completely new to general practice. And it's a fantastic way of demonstrating obvious things like the way that you consult, the language that you use, how you manage your time, how you keep records, most importantly, how to navigate the computer, like prescribing and looking up results and that sort of stuff. It can be very valuable. It can be even more valuable if you deliberately target this as a session with some goals. In other words, look, I want you, while you're sitting there watching me, to listen to how I greet the patient, or listen to how I manage a list, or watch how I end the consultation. It's really important for them not just to sit there and be passive about it. Even better, if you want to be clever about it, get the registrar to sit and type the notes while you consult. That gives you some additional information on how they listen to the consult and what they pick up as being important, as well as their written expressive skills. I'd recommend it, particularly if you want to demonstrate later on in a term, maybe how you do motivational counselling or something along those lines. Get them to sit in with you for that consultation and demonstrate with a bit of discussion afterwards as well. And that can be a great way to spend half an hour or an hour of your teaching session. Physical examination, Look, obviously, we all know, and probably some of us are just as bad, musculoskeletal is probably the single most requested examination skill. Some of us might also be a bit rusty on examining the shoulder or the knee, but it's a good excuse to look at some fantastic videos, of which there are hundreds of good demonstrations, videos of joint examinations, and using the opportunity to practice on each other, or if you've got a patient in with you, that's a really essential thing to do, because they don't get much of that stuff in uni or in hospital time. And procedural skills, well, it depends on what you like to do. If you're not a proceduralist GP, if taking a blood pressure is about as procedural as you get, then maybe this might not be something you're good at. But if you like taking things off or doing procedures, the best way to do it is to schedule a couple of removals or removal during the hour teaching session, or one of the registrars to schedule 1 or 2 patients, so that you can talk through the process. If you haven't ever read Susan Wern's very clear and sensible article in 10-year-old Australian Family Practice, it's a really great schema for how to deliberately teach a skill, which is a bit more subtle than see one, do one, teach one, but it does explain the stages of teaching a skill. Now, role play, and I think, again, most of you probably balk at the idea and think of medical school and having to role play some impossible character. It's a fantastic way of getting the registrar to rehearse even snippets of communication skill. Even a half a role play where you ask the registrar, for example, how would you ask this person a sexual history? Or how would you explain to a patient by role playing that you actually don't really know what's going on? Or how would you say no to a patient making unreasonable demands? Little snippets of scenarios where you just whip into being into character can be a fantastic way to actually practice, not say what you would do, but actually do it in front of you. Now, you could do half an hour of that in a teaching session, but it can easily be done ad hoc when you're doing a direct observation, or even in the middle of a case discussion where you decide, okay, let's have a go and see what you actually would have said to that patient. It can be a fantastic activity. There's no better way of learning something than having to teach it. Organising your registrar to look after the medical student or deliver a talk or a case to your practice is a fantastic way of getting them to actually learn a particular topic. And with your burgeoning teaching skills, now that you've attended all these webinars, you could even give them a couple of actual teaching tips on the way to make their teaching effective. Oh, and last of all, exam preparation. This would deserve a webinar on its own. We could spend an hour and a half talking about this. Essentially, you would have a role in either helping some role play cases or going through some actual written questions. GPSA teaching plans, which I mentioned before, all contain at least one kind of exam type question, which you could go through with your registrar. And certainly your training provider and the colleges provide a lot of guidance on how to help your registrar with exam preparation. But in that stage of training, we're ready for it, that can be a useful activity. Back to you, Simon.
Thanks very much, Tony. What a wonderful summary of what an extraordinary, rich cornucopia of teaching methods that we've got available. And thanks for picking the eyes out of those and really highlighting the strengths and utilities. As Tony, I think, really saliently said at the beginning, if we allow our registrar to drive things and we don't avail ourselves of the opportunity of the breadth of teaching methods, then commonly it will be problem case discussion, almost exclusively at times. But no matter what we do, commonly this will be what the registrar will be asking for and what will happen. So problem case discussion is by far and away the commonest teaching method. As we talked about, it's driven by registrar's learning needs. And I guess the nature and the urgency of the clinical situation. It's a form of case discussion, clearly. And as Tony alluded to, it has all those strengths of tapping into a registrar's clinical understanding, their tolerance of uncertainty, their clinical reasoning skills. Random case analysis does have that wonderful strength about being random and being able to pose what ifs, but there's no reason we can't do that with any form of case discussion, like problem case discussion.